Hi, welcome to the Nurse Coach Duo. This episode, we're super excited to have Dr. Becky Lynn back to discuss her takeaways from this year's International Society for the Study of Women's Sexual Health Conference. You'll remember Dr. Lynn from our Let's Talk About Sex episode. And if you haven't listened to it, please be sure to check the description for a link to that episode because it's definitely worth your time. Dr. Lynn brings us some exciting news from the ISSWSH conference, what's new and upcoming in the research of women's sexual health. Let me tell you a little bit about Dr. Lynn, and you'll see why we had to have her come back to talk with us today. Dr. Lynn's a board certified obstetrician and gynecologist at Evora Women's Health in St. Louis, where she brings compassionate and comprehensive care approach to women's care. She graduated from medical school at Georgetown University in DC and completed her residency at Washington University in St. Louis. Dr. Lynn serves as the adjunct professor of gynecology at St. Louis University of Medicine. She specializes in menopause and perimenopause management, sexual health, and medical weight loss. Dr. Lynn is a menopause certified provider, a certified sexual counselor, a fellow of International Society for the Study of Women's Sexual Health, a diplomat of American Board of Obesity Medicine, reflecting her expertise in treating weight-related issues, and the former president of the St. Louis Gynecological Society, highlighting her longstanding leadership and commitment to advancing women's health. Her career includes positions at University of Missouri-Columbia and SLU University before transitioning to full-time at Evora Women's Health. This is such an important conversation, and you will feel Dr. Lynn's passion and compassion right through the screen. If you haven't yet, please hit that subscribe button for more real talk about midlife. Before we dive in, just a quick reminder. This episode is for educational purposes only and isn't medical advice. If you're dealing with a health issue, please check in with your healthcare provider.
Hi, welcome to the Nurse Coach Duo. My name is Angie McGuire. I'm a board certified nurse coach out of Oak Park, Illinois, and the owner of Coach Angie.
And hi, I'm Jen Schroer, owner of Clarity Health and Wellness Coaching. And today we're welcoming back Dr. Becky Lynn to the Nurse Coach Duo. Thanks for coming, Becky.
Yeah, thanks for having me. Hello
Yeah,
again.
I almost said thanks for having you. That
I
doesn't
knew
make
what you
sense.
meant.
Yes. So when we were on last time, we talked a lot about sex and menopause, which was awesome. So we will drop a link to that episode in our description. It was such a important conversation, and a lot of people enjoyed it. So we wanted to have you come back today because in that episode, we talked a little bit about that you were ISSWSH certified, and you went to their annual meeting this year. And so let's just start by explaining what is ISSWSH, and then we can kind of dive into what you learned at the conference this year.
Yeah, so ISSWSH is a fantastic organization. It stands for the International Society for the Study of Women's Sexual Health. And I've been part of it for over 10 years now, and it's just grown by leaps and bounds. So it's a scientific organization. They do a lot of good. They have conferences. They teach practitioners on how to manage sexual problems in women. They have all sorts of courses, and then they have a yearly conference. And at the yearly conference, there's general lectures, but then there's a lot of research that's presented. And I love that about ISSWSH because you can see what's being studied, what's the up and coming thoughts on, issues that face women sexually. And the other thing I love about ISSWSH is like there's no embarrassment, no shame. Like we should all be talking about sex.
Yes.
It's part of health. And so I feel like having been part of ISSWSH and going to the conferences and meeting other providers, it just elevates the conversation so women can feel comfortable about having that conversation with their practitioner. So it's a fantastic organization. And if you're a patient or a not practitioner, they have a patient-facing website. It's called Prosela, and it's just got really good evidence-based scientific information online. And if you're a practitioner, they offer courses twice a year. So it's just, I can't sing its praises enough.
Yeah. I'm so glad that you mentioned that there's a patient-facing platform or website, because I was actually going to ask you that question. How, I mean, that's so important. And we as coaches and working with midlife, we always like to point people in direction in the direction of more education, more science, and not only to back up what we're saying, but also to make them more aware and increase their knowledge, of course. So thank you
Sure.
for including that. And I often hear from other providers, and you're just, putting the stamp of, again, like this conference seems to be one of the favorites out of many providers that I know that work with women in midlife. So it sounds a lot of juice comes from it. So
Yes. And it's a fun group of people.
yeah,
Yeah.
that's
So it's quite a fun party. Yeah. And
yeah,
just the people who are involved are wonderful.
yeah,
Wonderful. Yeah.
that's really great. It says a lot about people who are working with women around
Right.
sexual health,
Yeah.
right?
We all
So what were
care
some
about
of
it.
the key takeaways, especially with women navigating perimenopause and menopause?
Yeah. So the number of key takeaways, the number of topics discussed is really broad. But one thing that was discussed is sex after breast cancer. And, one little tidbit that sticks in my mind is only 5% of women get talked to about the changes to sexual function that are going to happen after a diagnosis of breast cancer. So, breast cancer, specifically hormonal breast cancer. So, when I say hormonal, like a breast cancer cell can have an estrogen receptor or a progesterone receptor. It doesn't mean that estrogen caused it. It just means that if you are on estrogen or you have estrogen from your own ovaries, it will stimulate that cancer cell to grow. So part of, the mainstay of treating estrogen receptor positive or progesterone receptor positive cancer is to block all hormones. And this throws people into an immediate menopause. And as you can imagine, they feel awful. And it's all in the name of preventing recurrence, right? There's a reason we do this. But what doesn't get talked about is the downstream effects of a quick cessation of all your hormones. So what happens is bad vaginal dryness, lack of arousal, lack of orgasm, low libido. And one of the things they mentioned, which I found interesting, and they were presenting some research, is that women's body image changes after breast cancer, right? Like because breasts are sexual organs, and all of a sudden now you might have had a lumpectomy, so things don't look quite right, or maybe you had a mastectomy, which is complete removal of a breast. And so body image changes. And one of the, I think it was an abstract that was presented, showed how women who have a lumpectomy tend to have better body image than women who have a mastectomy. Now, that doesn't mean all women should have a lumpectomy. Some will choose mastectomy, and that could be perfectly right for them. It just depends on so many different factors. But yeah, it was an excellent conversation about sex after breast cancer.
Mhm.
Yeah, and I love that all of it is like, scientific, it's research based, it's
Yes.
evidence based because that's so important, right? We're not just making a lot of assumptions here. We're actually talking about like things that we are seeing in true patient care. And
Yeah.
it's funny, I was just actually talking with somebody earlier today about, if you have the BRCA gene and all of these things. And I don't feel like that conversation is still quite had enough about estrogen, progesterone with
Mhm.
breast cancer, because what you keep hearing out in the media, anyways, that I'm hearing is just like, talk to your doctor. It's like,
Yeah.
yes, but I
Yeah.
need to understand what I can actually like support in that conversation.
Yeah, so it's really complicated and really nuanced.
Yeah.
So it depends on the patient. But BRCA, there's a variety of ways that we manage women with BRCA. And one good thing is that BRCA, having that genetic mutation that increases your risk of breast or ovarian cancer, that's what it is. It's not a contraindication to hormone therapy, which is a really good thing because sometimes women with BRCA will choose to have their ovaries removed when they're done having kids and done using them, per se.
Yeah.
But then that throws you into a surgical menopause.
Mhm.
But if you haven't had breast cancer, you just have the gene, you can absolutely utilize hormone therapy. And the other thing that's important about this is women with BRCA will often have their ovaries removed at a younger age than maybe someone who's like 55 having a hysterectomy.
Mm.
So this might be someone when they're done with childbearing who's maybe 37, 40. And that's a really early menopause. And you really need your own hormones to keep your bones strong, your heart healthy, your brain healthy, but also for sexual function. So, what I have seen in my career is women who've had an early menopause, a surgical menopause, either from BRCA or something else, is that they'll have their ovaries removed, they'll get put on estrogen, but nobody addresses their testosterone and nobody addresses libido. And it's a different story when you take a 55-year-old woman's ovaries out. Their ovaries weren't making as much testosterone as a 35-year-old. And so when you remove a 35-year-old's testosterone, you can really have their libido take a nosedive.
Right.
So a lot of what I do is help women with low libido, and I definitely come across patients who've had an early surgical removal of the ovaries and nobody replaced the testosterone. And once you do, they feel like themselves again, they get their libido back. The other piece of the puzzle related to sex in an early menopause in a BRCA person is the vagina. We cannot forget about the vagina. And when you give back hormones systemically, like a pill or a patch, it doesn't treat the vagina as well as giving something directly to the vagina. And it's so, so, so important. And that was another take-home pearl from the ISSWSH conference, which I think is so important, is that lubes and moisturizers should not be first line. Vaginal estrogen should be first line for vaginal dryness due to menopause. And pretty much anybody can use a vaginal estrogen. A person with BRCA can use it, even breast cancer survivors. So we don't have data to show that giving somebody vaginal estrogen is going to increase their risk of recurrence. So vaginal estrogen does a world of good for the vagina and then your sex life in turn. So yeah, that was another pearl from the ISSWSH conference. Like in so many of these algorithms put out by societies, they always say lubes and moisturizers first, but really we should be using estrogen first to treat conditions related to low estrogen. Sorry, that was
So yeah, no, I love this. So even with the 35, 37-year-old that is put into surgical menopause, that's really important to start that at that time as well, even before, just to get ahead of what happens to, the vagina as our, estrogen depletes.
Yeah. Now, the interesting thing is that sometimes, like in a natural menopause, so in a natural menopause, people will have like hot flashes, night sweats, their periods go away. Vaginal dryness may not show up for a couple years. But if you want to get ahead of the game and not wait for those symptoms to appear, then you can start a vaginal estrogen early. And it does a couple things and then more things that we don't think about. So the things that we know it does is it helps with vaginal dryness. So premenopausally, the vaginal tissue is thick, moist, makes its own lubrication. Postmenopausally, it doesn't have as many cells that make lubrication. It doesn't stretch. Sex can become painful. So we replace the vaginal estrogen and sex is not painful anymore. Sex feels better. But the other things that estrogen does is it brings blood flow to the vagina, it brings nerve growth, and it helps with orgasm. So that's another thing that menopausal women will sometimes say they can't reach orgasm, but they're so embarrassed to bring it up, or they're worried that something is wrong with them, right? Like, or their partner is worried. Their partner's like, am I doing something wrong? Why? How come you used to reach orgasm and now you can't reach orgasm? And sometimes they just need a little bit of estrogen back to the clitoris.
Yeah, I love how fluidly and openly you talk about it because I mean, I know you know and Angie knows, but like it's just so sad how we can't have these conversations and like you have to whisper certain words or what have you.
Oh
Like I was
no.
talking to some guy walking out from the gym the other day and I said, "Oh yeah, I coach women in perimenopause." And he jumped. I'm like, "You're jumping at that word. God, you could not be in any
I
conversations with me."
know. Oh, that's so funny. Yep.
Well, I was wondering, if you have more pearls, we're definitely open to more.
Mhm.
But was there anything kind of? I feel like social media is really has so much weight on people's information these days. Was there anything in the conference that was like you're hearing in social media all the time, yes, 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 and it's like no, or the opposite, like,
Mm,
because we just hear, I know I was actually
yep.
thinking about this driving here. I was like, out of the same doctor's mouth, you would hear, go drink a glass of wine to relax, which
Yeah,
is
no, don't do
now we
that.
know is a carcinogen,
Mhm.
but no,
Right,
you can't have estrogen because it causes cancer, so like we're
right,
hearing all of
right.
this stuff still from some of the
Yeah.
same people and that type of thing. So I was just curious
Yeah,
if there's anything that was like, let's just bite this and off and
yeah. I'm
put it
trying to
out
think
there.
because I do fight this battle every day
Yeah.
because Instagram is chock full of people trying to sell you a supplement to fix every single symptom of menopause and perimenopause.
Yeah.
And I feel like women are harmed by that. So I feel like the internet preys on the fears of women, right?
Yeah.
And as a woman, how do you know what's good information and how do you know what's not good information? It's impossible to know. And that's why I think it's really important that we have practitioners who can talk to you about your sexual health. So you don't fall prey to take this supplement, supports. They're not allowed to say it treats anything. Support,
Right.
supports libido. Um, and I feel like, especially when it comes to sexuality, women are embarrassed to bring it up. Or on the flip side, most practitioners are not trained in sexual health. And that's not their fault, right? Like they know how to deliver a baby. They know how to do a hysterectomy. They know how to save you from a postpartum hemorrhage. But a lot of the training in OBGYN, even in family practice and internal, isn't focused on sexual health. So women are afraid to bring it up, and then maybe their practitioner doesn't know anything about it, so kind of, dismisses them, not out of malice, but because they don't have an answer. And so women turn to the internet. And and just us talking about this, now my phone is going to be chock full of
Yes.
supplement ads.
Yes.
And there's really not a supplement that's been researched that has been proven to improve your sex drive. So that's like the first one that I can think of, um, is in the sexual realm. There's a lot of other misinformation out there, lots and lots. And the one that I can think of that is not sexual related is thermography as a means to screen for breast cancer. And I personally am upset about people who are trying to get women to do thermography because
Mm.
it's not appropriate screening for breast cancer. And 1 in 8 women will develop breast cancer, and mammography will pick it up early when you have the best chance of treatment. Thermography picks it up late, and it drives me crazy when I see people scaring women about mammography and telling them they need thermography because they have a thermography center.
Right.
And it is just so harmful and so wrong. So not related to sex, but that's my other kind of myth out there. And people who are, propagating these myths, they prey on fear because everyone's afraid of breast cancer. So they're like, oh my God, mammography's bad. Somebody told me it was bad. And then, they prey on fear. So that's the only other thing I can think of. But yes, the internet is wonderful for a lot of things, but it's also got a lot of misinformation.
Yeah.
Yeah. Thank you for sharing those. Can I swing back to testosterone because
Of course.
it's obviously related to sexual health as you've already said, and but it's really um, confusing for women
Yep.
because again they might see it on social media or their friend has started it, but their doctor won't even have the conversation, or they've just said to go and talk to your partner first, which I don't. I think it's a big ball of wax, right?
Yeah.
But how do you, I feel like we talked a little bit about this last time, but can you,
Yeah.
like, your assessment and how you would advise someone to go into a practitioner they already see and how
Mhm.
to really come in and advocate for themselves that they really want to try testosterone?
Yeah. So I'm going to answer that question first. The
Okay.
problem is not every practitioner knows how to prescribe it. So even if you're an advocate for yourself and you know
Yeah.
what to say and you know what it's indicated for, your practitioner might say, I have no idea how to do that. So if you feel like you're a candidate for testosterone, what you want to do is go to the ISSWSH website. It's ISSWSH.org, and you can find a practitioner who's well versed in sexual health because not everybody is. And even a lot of OBGYNs, they just don't know how to do it because they weren't trained. But back to the testosterone question. This is a huge question. And even within the world of experts related to testosterone, there's controversy, which I find really, really interesting. So there's been a lot of research on testosterone in women. We have plenty of good data to support its use for low libido and sexual problems like arousal and orgasm problems. So we know we have good, solid evidence that testosterone can work, not for everyone. So there are a couple review papers put out by the Menopause Society, put out by ISSWSH, that are sort of a consensus statement on testosterone use in women based on the research. And what they say is that the indication is for low libido. Now, there are people in the menopause space who believe that testosterone should just be replaced for everyone. Like Kelly Casperson, who I love. She's a wonderful urologist. She is very pro testosterone. And then there's Susan Davis on the other side. So Kelly she puts out data. She does put data out there, mostly some smaller studies about using testosterone for other things besides libido, like for brain fog or bone density or muscle mass, right? Not big double-blind randomized placebo-controlled trials, but we don't have those.
Right.
So what do? Do you have to wait until all those trials come out? On the other hand is Susan Davis, who is the world's most renowned researcher on testosterone in women. She's the one who does all the big clinical trials. And she is more of a, hey, we don't have enough data to say that women should be on testosterone for their bones. We don't have any data to say that women should be, or any significant big clinical trials to say that women should be using testosterone for muscle mass. So even within menopause and sexual health experts, there is disagreement, and it's kind of interesting to watch. Where I fall somewhere in the middle. The way that I practice medicine is if someone comes in for low libido, well, first of all, we need to figure out why they have low libido, because if you have not a good partner, all the testosterone in the world is not going to make you want to have sex with that person. So you have to do a deep dive into what's contributing. But I definitely prescribe testosterone for low libido. Now, if someone comes to me and they're like, I really want it for muscle mass, I want it for energy, right? A lot of people have heard it helps with energy, and everyone's tired in their late 40s and 50s. I am too. So I will explain to them that we don't really have a lot of data to support that use, the use for that. But here are the risks. Here are the potential benefits. Here are the side effects. Is this something that you want to do? So I'm not so hard and fast with, I will only use it for low libido. I don't, but I feel strongly about giving women the information. Here's what we know. Here's what we don't know. And then they can decide if testosterone is something that they want to try. So long story short, even within a menopause expert, it's highly controversial.
Well, I mean,
There's an outlet.
Right. There's a science and there's an art, right? And I think that what you're talking about is the art piece of it. If we're using medicines off label all the time.
Yep.
So to be able to just say, well, there's no data to support that, so we're not going to do it. Like you said, let's talk about the risk. Let's talk about the benefits. And if you want to trial it, we're not putting you on something that doesn't have any data. And I've heard as well that we have, years and years of data in the transgender realm, right? And that's very high dose testosterone.
Yep.
So it kind of helps you feel a little bit better about the risk in my mind whenever I think about that, right? It may not get me what I'm wanting it to get me, but the risk must not be that bad because we're giving them way higher doses than I would ever ask for, right? Just for muscle or sex.
100%. But we do have good data that it's not harmful in the long term.
Yeah.
So, I'm not too concerned that I'm doing something dangerous.
Right.
I'm more concerned that I don't want them to have side effects, because you have to be very careful with testosterone, because if someone's testosterone gets too high, they can have permanent side effects. So they can have deepening of the voice, male pattern baldness, the clitoris can grow to a small penis. There's all sorts of negative side effects. So with testosterone, we have to be careful and follow the blood levels just to make sure someone doesn't get too high. I'm more
Great point.
concerned about that than some big bad, dangerous,
Right.
it's not going to cause breast cancer, or, it's in the right patient, not going to cause a heart attack. So yeah.
Yeah, no, great point. I'm glad you added that in there. But
Mhm.
so what, any other kind of key things that you wanted to make sure to mention today before, and I don't want to like ask another question in case you had some burning things you wanted to tell us.
I don't, well, guess I have one little burning thing, which I think is huge.
Okay.
So for like 10 years now, we've had a medicine called Addyi,
Mm,
which is for low libido, and it has been up until recently for premenopausal women. And it doesn't work for everybody, but it works for many women, and it is life-changing. It works through dopamine and serotonin. It is not a hormone, and it's a really good tool to have in your toolbox. And recently, it got FDA approved for women up to the age of 65. So this is huge because insurance won't pay for drugs if they're not FDA approved. So if you're 55 and you have low libido and you want to try Addyi, your insurance will not cover it. But now it got approved for women up to 65. And this is life altering because when it comes to low libido and choosing a medicine, and not everybody has to use a medicine, there are a lot of things you can do for libido that have nothing to do with medicine. You have three options in a postmenopausal or a perimenopausal woman. You can do testosterone, you can do Addyi, or you can do, well, okay, let me back up. In younger women in premenopausal, so far you've had Addyi, and there's also a medicine called Vyleesi. And in postmenopausal women, you would have testosterone, and you would use Addyi off label because there is data. There's good double-blind, randomized, placebo-controlled trials showing that Addyi works in postmenopausal women, but it wasn't approved. So now it's finally approved in postmenopausal women, which is wonderful because it's the only drug that's FDA approved for low libido in postmenopausal women. And if you look at the percentages of women who have low libido, it's much more likely to happen in the postmenopause, which I use interchangeably with menopause. Postmenopause and menopause are the same thing, versus a premenopausal woman. So this is wonderful, huge news.
amazing. I'm sorry. I'm glad that you
Yeah,
said it because that is actually the question I was going to ask is what did you hear at Addie? So I just wanted to
yeah,
clarify one thing and then I'll let Angie ask her a question. But when you
sure.
say that, like, I think you said 65, right?
Mhm,
So if someone starts it at 55 and they hit
mhm.
65, if it was still today, would they have
Yeah,
to stop it?
I would probably leave them on it as long as they weren't having any negative side effects. You have to be careful because some of the side effects are dizziness or drowsiness. And sometimes you have to be
Yeah,
careful with older
all
people being
risk.
dizzy. You don't want them to fall.
Yeah,
Um, but we've used it in postmenopausal women. There hasn't been an age cutoff
yeah.
until now. And so if they were doing okay on it, and I would be more concerned if they were on other medicines that made them dizzy. So I
Sure,
guess the answer is you have to look at the whole picture.
sure. Makes
Yeah.
sense. Thanks.
I was just going to say that, all over social media today is about the film that, oh my gosh,
Yep.
excuse me.
Yep.
The film that is dropping, I think today
Today.
or tomorrow. Oh,
It's
today.
today.
Yeah. On
Yeah.
Paramount Plus.
Yep.
And
I can't
it's
wait to see
called The
it.
Pink Pill. What's that?
Yep. I
Yeah.
have not seen it. So they showed it at ISSWSH, but they
Okay.
showed it on the last night, and I went home and visited my mom and my dad, and I missed it. So I'm
Yeah.
really
Okay.
excited that it's tonight. Yes.
Yeah. Yeah. I look forward to watch. I can't see it tonight, but I will hopefully this weekend. But
Yeah.
that's a huge success. So it's just one more step for awareness. And
Yeah.
Rachel Rubin on her was all about, get your free 7-day pass to Paramount Plus, and
Yeah.
you have
Yeah.
access to it,
For
and
sure.
then close it down.
Yeah.
So
And so, yeah,
we
go
should
ahead.
all, if you have a streaming platform, you should be able to see it.
Yeah, I think it's an amazing story. And I'm
Mhm.
really curious how they'll tell it. But, the story goes, it got rejected by the FDA, I think twice. And it's craziness, the difference between the standards, right? To get a Viagra approved, you didn't really have to have long-term safety data, right? But to get a medicine for women approved was a huge hurdle, like so much harder than Viagra, which is ridiculous. And the one story that I've heard, and I can't remember where I've heard this, it might have been from Cindy Eckert, who's the owner who created Addyi. It's her story. Um, about like, insurance companies, when Addie got approved, they'd be like, oh, well, we won't pay for this unless you do marriage counseling. Well, who said that to men about Viagra? We're not
Right.
going to pay for your Viagra unless you do marriage counseling.
Wow.
Total double standard. So,
Yes.
yeah, Cindy Eckert's amazing. She worked incredibly hard to get this approved, despite the major roadblocks, hurdles. It's crazy. And I remember when it first came out in 2015. Here's a story for you. Talk about like the patriarchy, double standard. I was at SLU at the time, and I'm a sexual medicine expert, been so for years. And one of the things that when Addie came out, like, oh, everyone was, reporting, oh, really bad side effects, hypotension, low blood pressure, blah, blah, blah. So when Addie came out, who did the media interview about it? They didn't ask for me. They interviewed a cardiologist,
Oh,
a male cardiologist. I'm like, what the?
right.
They didn't, and the thing is, there was all this, upheaval about, oh, the side effects are so bad, and it only gives you zero point 0.5 or whatever better sexual side of or sexual events, more satisfying sexual events. And I just couldn't believe that they interviewed a cardiologist, a male cardiologist, about a drug for women's sexual health. They didn't come to SLU to ask me to talk. The other thing that I want to say, and part of the reason like it got so much negative press, is that when you do clinical trials on a libido drug, the FDA tells you have to do it, how you have to do it, what your primary outcome has to be. And the primary outcome is sexually satisfying events because that's what they use in the Viagra trial. So it has to be the same. So it wasn't desire, right? There are ways
Right.
we measure desire on like the FSFI, which is a questionnaire. You can get a measure of desire. They had to use sexually satisfying events. And I can't remember the exact numbers, but it was not quite, maybe it was one more sexually satisfying event. It wasn't a huge number. But when you think about what you're looking for is, did it improve drive? Let's talk about, was this a sexually satisfying event? Let's say your kid knocks on the door. Like, no, you have to
No.
stop. That is not a sexually satisfying event. But is sexually satisfying events, is that a good surrogate marker for desire? Not
Right.
really. There's so many things that play into it. But the FDA, that's how it has to be done because that's how it's done in men. And so it got all this like, oh, the media painted it as horrible side effects for very little benefit. And I'll tell you, because I've been using it for 10 years, I don't have people have horrible side effects. It
Right.
doesn't work for everybody, but you know what medicine does. But the people who it works for like it. They like how they feel on it.
That's great.
And the other thing I'll say about Addie, and I always kind of let my patients know this, it's not going to make them crazy, horny, dangerous to take outside. But that's not really what we want, right? They're not going to want to have sex with everything,
Yeah.
which is a good thing.
Yes.
So, what I find is that people feel a little more open to advances, maybe more sexual dreams, maybe more spontaneous sexual thoughts, and they like that. And so, for those people for whom it works, that's typically, not everyone, but typically how they feel.
Yeah. Yeah. I really would love to have like a pre-questionnaire for those people about sexually satisfying. Like, was that, did you have that beforehand? Like before you
Yeah.
lost your drive? Like, because like
Yeah.
just because you're taking a pill doesn't mean you're going to now suddenly be satisfied. Yeah, that's just
Right,
crazy.
right. There's so
Yeah,
many things that go into satisfaction, and it's not, I
exactly.
don't think it's a good surrogate marker for drive at all.
No, no, not at all. Well, so what are you looking forward to for next year's event? Was there anything that was talked about maybe this year that was kind of introduced that you're going to learn more next year, or things, studies that you heard about that you're, or maybe even that you're hoping that they'll do?
Yeah, so there was one lecture where they looked at, and I'm going to get this all wrong because it's kind of newish,
Yeah.
but sort of pelvic congestion syndrome,
Mm.
where people get like dilated blood vessels in the pelvis. It causes pelvic pain. For many years, it's been sort of, does it really exist? Does it not exist? But they had a radiologist talking about it. It was a fascinating lecture. I can't give you all the details because it was new and things don't stay in my head. But now as radiology advances, they have higher tech to be able to look at the congestion in the vessels. And so that was the first time that I've heard any of that discussed at ISSWSH. So And what happens is as over time things change, then when you find something, then you start to hear more and more about it every year. So I do hope that we hear more about
Yeah.
that next year. And next year, the ISSWSH conference is in Vancouver. So yes,
Mm,
I would like to
Fun.
go there. So yeah.
Yeah,
yeah, well, that's great.
absolutely.
Well, I feel like we could talk to you for hours and hours.
Of course.
And always, I just think you bring so much great information to us and to our listeners, and for us to also take away to our clients. And so very grateful to have you. And I don't think this is the last time either. I hope not anyway.
Happy
But
to come back.
if you, yeah,
I
if you
like
had one
talking.
goal or one thing to leave our audience with that, around sexual health, and gosh, I know this is a loaded question, what would
Yeah.
it be for today?
Yeah. You're not broken. This happens. And one thing about sexual health, one thing I like to say is that the longer you live, if you live a good long time, you will develop vaginal dryness and maybe painful sex as a woman. And the longer you live as a man, you will develop erectile dysfunction. And sex changes over the course of a lifetime, but it doesn't mean you have to accept painful sex. There's plenty of things you can do, and it may not be the same as when you were 20. It probably won't ever be the same as when you were 20, but you can continue to have sex for as long as you're capable. There's no like cutoff age where you have to stop. And if you have dysfunction or problems, there's plenty of treatments for it.
Love
I
that.
think
I
that's
feel like we need a
it.
little mic drop after that because that was perfect.
Mic drop.
Absolutely. I love that. Like just to me, hopefully anyone who's listening, they just felt like open, accepted, understood,
Yes.
a little bit more calm and ease about what is to come because you're
Yeah.
right. Just like menopause, all of this is going to happen if we are lucky enough to live
Yes.
long enough, right?
Exactly.
Amazing. So, can you just remind everybody where to find you so that
Sure.
when I know they're going to want to be able to find your website and your Instagram, everything?
Yep. So I practice in St. Louis, Missouri. My website is evorawomen.com, and that's E V as in Victor, ORA, women, WOMEN.com. Evora Women's Health has an Instagram and a Facebook that's at Evora Women's Health, I think. And I also have one. I'll send you the final one so
Yes.
your listeners have it for sure. I also have one that's at Becky Lynn MD, and that's on Instagram and Facebook. And I also have a TikTok that's Dr. Becky Lynn. Um, I kind
Amazing.
of sporadically will post a whole bunch of videos, then be gone for a while, then back again. So, but there's a lot of good snippets on there about sexual health, menopause, and weight loss, which are my specialties. So, yeah,
Amazing. Awesome. And we will make sure we put everything in the description below. So thank you so much again for coming. If you like this episode, please make sure you like, comment, subscribe. And if you have any questions that either Dr. Lynn, Angie, or I can help you with, please feel free to reach out. Thanks again, Becky.
you're
Thank
welcome. Have
you.
a good one.